everybody. A very warm welcome to the Financial Services Conference, ReGenerations Reimagined. We're currently in week 5 of our twice-weekly events, and we've had some absolutely fantastic conversations over the last few weeks, and certainly coming up over the next few weeks. But today, absolutely delighted that for the first time at an FSC conference, we're going to have a really interesting and deep dive into the health insurance conversation, that in particular with reference to ACC, key funding models and value-based care. And we've got a great lineup today. I wanted to acknowledge and thank all the sponsors that we had on that previous slide. Big events like this only happen with great support from around the marketplace. And wherever you are in New Zealand, if you're in Auckland, obviously we're still locked down. If you're lucky enough to be outside of Auckland, hopefully your lives are rich and connected. But obviously from a conference perspective, disappointed to not be able to be with everyone in person. But obviously keeping people safe, taking guidance from government is first and foremost what's important to us. So without further ado, this session in conversation with Graham Dyer has been curated by the FSC Conference Committee. This particular session is sponsored by our generous partners and friends at AIA, so thank you to them. And without further ado, delighted to welcome Louise Zacest and Graham Dyer to effectively have a conversation and explore a number of the issues that are that we as a sector are facing into. It's been 11 months since the health community, the health insurance community, has joined the FSC, and it's been a really interesting and valuable journey. So to all of the people in the health insurance community within the FSC, a very warm welcome. Thanks for joining. And without further ado, I'm going to hand over to you, Louise, and to Graham. And thanks for taking us on a journey over the next 50 odd minutes. Over to you. Thank you.
Thank you very much, Richard, and welcome everyone to this session. Like Richard, I'm really looking forward to hearing what Graham has to say, and I'd also like to acknowledge the support that we have from our sponsors today. And it is my privilege to introduce Graham. I was talking to him the other day and realised that it's about 15 years since I first came across Graham when he was working in the DHB sector, and he's got a long and strong background across the health sector from both a healthcare delivery perspective and a health funding perspective. And he tells me it's 25 years in total, and 20 of those have been in senior executive roles, including CEO roles and executive management roles. And they've spanned both the operational management side of things as well as planning, funding, finance and ICT. So as you'll find as Graham talks today, he's got a lot of knowledge and a lot of expertise from various facets of the sector. But today, he is going to focus on some of his knowledge and experience that comes from his time at ACC, where he led the provider services team and was responsible for the commissioning of in excess of $3 billion of healthcare services. Repeat that figure again, $3 billion of healthcare services across the country. And Graham stood back from this role to pursue a doctorate in value-based purchasing in healthcare. So pulling together all his practical experience, he is now drawing, I guess, on an academic background to look at best ways of moving forward. And alongside that, Graham is involved in consulting work, including with clients such as the Ministry of Health, the Office of the Auditor General and Southern Cross Health Insurance. But currently, because there's no rest, Graham is in a locum CEO role at Whanganui DHB and is supporting the work in the health reform as well as completing his doctorate. So with that as an intro, I hand over to Graham and really look forward to what he has to speak to us about. You will have questions, I'm sure. After Graham's presentation, we will have a bit of Q&A. So any questions you have, if you can pop them in the Q&A box, that would be fantastic. Thanks, everyone.
Thanks for the introduction, Louise. And I've got a bit of a presentation, so I'm just going to share a screen here. So hopefully, right, that will all come up. Is that all clear? Thanks. So what I really want to talk about here is the talking about ACC, and it was in the header it said part of ACC, and I think as Louise just noted, I left ACC a little while ago. But it's want to reflect on some of the time there and some of the key funding models, which are very applicable across the private health sector, as well as representing some of the international change, and particularly the move to value-based care. And starting on that, it's found a quote here which I thought really covered this from an objectives point of view, and it's talking about in the last century that healthcare was dominated by clinicians' effectiveness and efficiency, and really systems that were built around clinicians, around hospitals, around delivery mechanisms, as opposed to being built around patients. And what we're seeing in the 21st century, which I think is familiar with a growing information age, is systems and demands that are really focused more on patients, on outcomes and value. And I'll keep coming back to this concept of value. And value-based purchasing is really set up to help ensure that the limited resources that we have are used as effectively as we can. So really in that pursuit of value. So just looking then at the big picture of why is this important? Well, the need for healthcare is growing at an unsustainable rate. It's what we're seeing is really three causes of this. First of all, the aging population. And in the top right-hand corner of that slide, I've got some projections of populations at different ages, above plus 85, plus 75 in New Zealand. And next to that, a graph from the Ministry of Health showing public health costs of people once they were actually hitting those age brackets. And so multiplying the number of elderly people by those costs, you can see that cost growth coming through. With that, the growth in also new diseases is a change, and the COVID environment that we're in at the moment is probably as good an example of that we could actually get. But then the third area is really new technology, and again a good example of this. If we look at just hip and joint replacements, the first modern hip replacement was done around 1969. And in the time from there to now, this has become almost a commodity. We've now got the robotics coming into joint replacement, and while the robotics are definitely adding a cost at this point, there's a lot of the literature says there's no really discernible quality increase in what we're seeing, but it has likely become more and more the norm in how we do things. So that has an impact then on health spend or GDP, or health spend as a percentage of GDP. And getting a little picture here, the line at the top up here is the US. No prizes for they're in a bit of guessing they're in a bit of a world of their own. But interestingly too, down the bottom here is New Zealand, which sits fairly flat in those 4 years up to 2017 when this was done. And probably that constrained spend as a percentage of GDP is partly explains some of the challenges that we're seeing in the health sector at the moment, particularly in the public health system, where growing DHB deficits and the impacts that has across the sector. Taking that a bit further and thinking of the context that we're operating in, it's a chart here that I've looks at the OECD breakdown of OECD countries' spending in healthcare, and I put a circle around New Zealand in there. Now, context here is important to understand when looking at healthcare purchasing that predominantly in the OECD, it's an insurance-based system or compulsory insurance-based system where there's a funder and multiple competing providers. And if we look at this, New Zealand and UK look fairly similar, with the exception of this little thing here, this what represents 9% of the health spend in New Zealand, which is ACC, as a compulsory insurer. And what we see here is some changes that are, or the opportunity to actually start looking at some of the changes. So New Zealand is still predominantly a health-based or state-based system, with the compulsory insurance, voluntary private insurance, and out-of-pocket charges being a smaller component. Now, I want to talk a bit about the value and talk about value in healthcare. And value can have different meanings to a number of different people. From a funder perspective, it is that Pareto maximisation of benefit for the spend. It's wanting to get the most for each dollar that's actually put out there into the marketplace. From a patient perspective, it's the outcome achieved. And if we use again the hip replacement example I talked about before, the funder, it's saying, how can I get this for the best price? A patient may not be so concerned with the actual operation or the procedure itself. What's important here is from an outcome perspective, could be walking without pain, without being able to walk in the park with grandchildren. It's not necessarily the same as is viewed by a funder or by a clinician. Clinicians typically look at how do they optimise their department, their area that they work in, and ensure that they're getting the maximum value they can from the component that they are actually experts in. A manager's view, particularly a hospital manager's view, is looking at effective and safe care within the resources that they have available. So it's avoidance of infections, it's avoidance of things going wrong, avoidance of over long stays, of pressure injuries, that sort of thing. Healthcare industry, people who are supplying products to the healthcare industry, very much interested in their actual sustainability, for drugs, for prostheses, for the different components. And the public's definition, when we're thinking about it as a public, as a population side, but we're looking and saying, what is the relative benefit I get from investment in healthcare versus, say, education, defence, other options that are available at a particular country level. But with these variations in value, there's a definition that's becoming more and more accepted as the definition of value in healthcare. And it comes from Porter and Teisberg back in 2007 in a book called Redefining Healthcare, where they define value as outcomes that matter to patients relative to the cost of delivering those outcomes. And so while there's considerable literature that's been developed about value-based purchasing approaches and value in healthcare, there are limited attempts to actually quantify that actual value component and say, what does it mean? Now, it's fairly easy to capture the cost of delivering services. There's a huge amount of work done in private, public, and insurance industries in actually capturing those costs. But I think there's less science that's applied into that numerator side of it, the outcomes that matter to patients. And I'll come back to that a little bit later. And while on this topic, I also wanted to talk a bit more about what we actually measure in healthcare. And I've got to the right of the screen a little diagram I've borrowed from the World Health Organization, and they looked at monitoring and evaluation of healthcare systems. And I came across this when doing a bit of work for the Office of the Auditor General earlier this year, and it was looking really at DHB accountability measures. And one of the measures came across, listed as a system level measure, was actually the number of children identified in a preschool check as being obese that were referred to for a clinical assessment. Now, to me, that's at best, that's at an input level, that lowest level of assessment of a health system. At an output level, it would be the actual clinical assessment took place. At an outcome level, it would be that there was a change in the kid's BMI, that there was actually a physically discernible movement in there. And the impact at an individual level would be looking more at saying, what is the impact on someone's long-term health? What is the impact on cardiovascular disease, on diabetes, from actually having those interventions right at the beginning? And what we tend to have is in measurement, in private or public, is at a predominance in that input and output level. And what we're talking about here in value-based purchasing is getting more and more to this outcome and impact level in what we're doing. And that's really is the gap that I'm seeing in the literature and in the practice is how do we measure that? How do we test the efficacy of that value-based purchasing and seeking value when we're looking at healthcare? Now, if we're looking at that, then from a healthcare funding point of view, we want to have a look at some of the current purchasing paradigms and some of the challenges we've got with that. The predominant purchasing system in healthcare is a fee-for-service basis, and this is on a little chart from developed by Harold Miller back in 2017, and he puts on this a risk of overtreatment and undertreatment on the x-axis, and whether or not a funding mechanism gives accountability for the outcomes and accountability for the costs, the Porter equation, and what it does. Fee-for-service, which we see as the most predominant payment mechanism in private healthcare, it's relatively simple, but it rewards activity over outcome. So the more I do, the more I get paid is the driver there. So it will drive relatively high levels of treatment, but not necessarily that focus on outcome. Moving on, if we look at where some health systems are going, and Medicare in the States in particular, it started looking at bundled payments for episodes of care, say a hip replacement, a knee replacement, some forms of spinal surgery. By doing that, they're starting to get more into this focus on accountability for outcome and accountability for costs. But still, they've run the risk by saying there's a single payment for an episode of care of introducing new perverse incentives, and in particular, cherry picking and lemon dropping. So again, work out of the States has shown that the cost for many of these procedures is relatively predictable based on some big data projections based of where people live, their age, socioeconomic status, access to services, etc. And so by sticking with a single price point in there, there are some advantages and drive some good behaviour, but it also, as I say, drives some perverse incentives in there to pick what people want to do and versus what they might not want to do in delivery of services. Next one I want to pick on is capitation, common in New Zealand around general practice, and useful because it's a low risk to a funder because it's a transfer of accountability to a provider, therefore quite a popular mechanism. The downsides of it is it tends to incentivize undertreatment. I'm paid whether I provide services or not. In a GP situation in New Zealand, the more I enrol, the more I earn from a capitation system. And there's also in that an incentive to cost shift to other providers. If I can write a script, if I can write a referral, that gets somebody out of my office, it means that the time I need to put into them is less than what they might actually need. And and by this I'm not challenging professional ethics. It's saying what are the systems actually incentivize. Population-based payments used currently with DHBs to say here's a funding mechanism for a population. It distributes funds, but it doesn't actually distribute based on need. It doesn't say that this is a sufficient amount. So again, it tends to drive a rationing approach and so a level of undertreatment, but it's getting better as far as actually promoting efficiency and effectiveness and accountability for patient outcomes. And where we're wanting to get to really with this value-based purchasing and is this idea of a patient-centered payment of it's focusing on value and the things that it needs, which we probably haven't had to the same degree in the past, is a sophisticated funder that can establish systems for remuneration, systems for payment, which are going to incentivize this focus on a patient outcome, but also needs a more sophisticated provider who can understand what those needs are and actually deliver a whole chain of treatment intervention from go to woe. So it is actually a patient-centered treatment and patient-centered focus. So narrowing this picture down and talking about some of the things that we've done at ACC when I was there. The ACC is a commissioner of health service, and last year spent little in excess of $3.2 billion in healthcare, and it's experienced inflation of around about 7% per annum. So pretty much the same as what I'm seeing in most insurance companies, which gets passed on to the population either as premium increases or as AC's cases as increase in levies that are collected on income and through other compulsory means. Now, where ACC is probably different from most others is it has a lifetime liability for the costs associated with an injury. There's no policy that says that there's a cap or a limit on these things. And ACC wanted to test value-based purchasing with a range of options and range of areas, including value-based purchasing. And at this point, also want to talk a little bit about the role of commission, this idea of a healthcare triangle. Now, in this, what we say in any health system, which isn't just a straight user pays, there's a population of some sort who either through tax or through insurance will consolidate or risk pool their funds into a commission or a funder of services, who in turn purchases services from providers who then deliver services back to that population. Now, if we're talking about value-based purchasing being interested in outcomes, we've got a commissioner here that is attempting to do that, who has a direct relationship with the population, direct relationship with the providers, but is not party to this delivery relationship where arguably the magic happens in this treatment relationship. So as a commissioner of services, what ACC is trying to do and what other funders are trying to do is to actually influence this delivery relationship, and doing that through smarter, more intelligent purchasing. So if we think about what does this mean from a model point of view, and I quite like this model when thinking about it from an ACC point perspective, sort of showing someone falling off a cliff as if having an accident. The ACC doesn't have a relationship, direct one-to-one relationship with participants prior to an accident occurring. It's a revenue collection through various means, and that relationship really starts where someone actually has an accident, where they fall off the cliff. And when somebody has an accident, has an injury, or actually any type of illness, there's really three components to it: a diagnosis, a treatment, a rehabilitation component. And whether that's a stub toe or a traumatic brain injury, it's those three parts exist. They're just going to be quite different in their magnitude and their scale. And what the traditional funding is trying to do is get people to a point where they actually are recovered from the injury. One of the challenges that exists for ACC, and this comes in back to this lifetime liability, is once somebody's recovered, are they actually going to stay well? Are they going to, or are they actually going to drift off again or re-injure? And again, when looking at a value-based approach, it's saying how do we actually minimise the risk of this negative impacts after someone's actually exited the scheme, exited their treatment pathway. And this is where some of the escalated care pathway work comes in. So the initial proof of concept work that was done around bundle payments for an outcome is taking this thinking around a traditional sort of diagnosis phase of getting to a definitive diagnosis for an injury, and then purchasing component-wise the rehabilitation, specialist impact, hospital rehabilitation, etc., and saying actually from a point of a definitive diagnosis that actually want to buy an outcome, buy a well person at the end of it, which is really moving from that purchasing of outputs to purchasing of an outcome for that individual. Now, with the work that was done with the ACLs, and this was done with a group of orthopaedic surgeons, 2 private hospitals and a rehab provider in Christchurch, and the evaluation, independent evaluation of the work done from this bundle payment indicated that there was a shorter time to surgery, a faster return to work, typically 7 weeks compared to 11 is the norm, and the standard deviation halved from 4 weeks to 2 weeks around that return to work time, which is, I found, more significant than the reduction in time because it's showing that there's a standardisation of process. And also lower levels of re-injury, but remembering that this type of work takes a fair bit of time to get the evidence base to say that this has actually been effective. So taking it back to the model, it's saying that person has an injury and we're moving a bundle payment to actually get to an outcome, which actually had the impact of shortening that recovery time reducing the weekly compensation that was paid. And again, what we're seeing, but need more time to prove, is that there's a lower level of re-injury that comes from actually having that bundled payment and the measurement of an outcome. So what ACC then did is said, based on the success of this proof of concept, it wanted to test the value-based approaches in the biggest areas of surgery. So looking at spinal surgery, knee injuries, and shoulder injuries. Now, the data was supplied to the market, showing the impacts that had occurred in the ACL work, and a request was put out through an RFP, through a commercial means, for proposals based with a single consortium of providers, a single payment made for an outcome. From those, there are 23 responses received, 8 shortlisted, 6 trials were initiated, 5 of which are still continuing. And the process involved a co-design with the successful providers. Now, lots of lessons learned from this, and if doing it again, there'd be, I think, quite different criteria that were put into that initial phase to actually get it up and running. But it's a different conversation. But the outcome of that, or the current state of that, is that the lead indicators that were developed and being tracked are by and large being hit. And 2 years in, the ACC's still continuing with the program and looking at what the impacts of this are, and particularly the indicative long-term impacts. And so this is a particular interest to me, because this is a lot of what I'm basing some of my PhD in. Now, comes back then, we talked a lot about value. I just want to pivot a bit at this point and talk about measuring value. Now, the Teisberg Porter equation, as I said, has been well accepted in literature. It's well accepted with people talking about it, but there's very little that I found in actually trying to measure value or quantify value in this. With the denominator of the equation, the cost of delivering outcomes, is readily available. It's typically well understood. We can see that from an insurance payment point of view. It's the numerator that outputs the matter to patients that is the bit that's a bit trickier to actually measure. And what we're seeing, I think, internationally is an increasing focus in patient-reported experience measures, patient-reported outcome measures, as a proxy for this outcomes that matter to patients, and being able to objectively measure the patient's perspective of their health status pre and post an intervention. And from that, by converting that through a value set, turn it into a currency, so we can actually compare procedures with procedures. We can compare the value gain from different treatments for a similar condition. We can compare value gain across various providers. And this can be used then to inform decision-making for consumers about what they might want to actually look at, where they might want to go, what they might want to do. But also for funders, for thinking about rational decisions when working in a constrained environment. And the prems and proms type approach and putting a quantification of value on intervention has been used in the UK and turned into a quality adjusted life year measure for some conditions, and used quite strongly or quite significantly in some funding decisions that are being used there. So, applied to the insurance model, what does this mean? I think unlike ACC, there is an insurance policy or an insurance arrangement with an individual. It means that there's a relationship, a one-to-one relationship that exists prior to any health condition or accident actually occurring. So there's an opportunity there to say, how do we maximise the wellness for somebody? How do we use this existing relationship to keep someone well, to delay the onset of illness or disease? And if that does happen, how do we actually get early detection and so early treatment? Now, what are the opportunities then when early detection occurs or detection occurs? to manage treatment processes for targeted outcomes, for this focus on the outcome that's important to the patient in there. And when somebody actually has recovered, what are the opportunities to monitor and maintain wellness post-recovery? What does this look like? And how do we actually keep someone well and continue that value delivery back to an individual? Now, these are the areas that I've put as questions at the end, because it's really for further work and further research. And I'd like to finish there and answer any questions.
Thank you very much, Graham. Some really interesting, thought-provoking points, I think, that you made as you were working through. I'm sure we will have some questions coming through. I just checked before, but I've got one to throw at you, which is, if we look at value-based healthcare, value-based purchasing, what barriers do you currently see within New Zealand to effective implementation of this model?
Yeah, look, it's a really good question, Louise. It's not something to be. You can't say we're just going to do a little bit of value-based purchasing, or we're going to go from an existing system to a value-based system. It needs to be taking it at a patient level and saying, this is what we're going to do, or this is what we're going to invest for this person, because we want to actually buy an outcome. From a funder point of view, that's then looking at systems and saying, what do we want to cover with this? What do we want to measure as the outcome, and how do we actually devise and develop systems that bring that subjective view of the patient into the measurement of the outcome that we're seeking to get. And equally, from a provider point of view, there's a challenge there to say, how do we, if this is what the funder is saying they want to purchase, how do we actually link together a whole lot of different providers who have tended to work autonomously, who have built their own IT systems, have built their own ways of doing things around their own business, as opposed to saying building a system around a patient to get them from an injury or illness to being well at the end of it. And examples of this from ACC experience, physios had systems that worked in physio practices. The consultants had systems that worked in their consultancy practices. Hospitals had systems that worked in their hospitals, but none of them were structured so that they could be joined together and build a single view of that patient and manage that patient journey. So there's investment to be made in both the funder side and in the provider side to actually move from a traditional system to something that's different.
Yeah, so quite a bit of sector change that's required around that. And Graham, how do we make sure we hold on to the patient, the customer side of things? Coming back to your triangle, and you were really talking about contractual models between funders and providers. How do we keep the person at the centre?
I think that again, that's a really good question. I think it has to come back, and we have to build into the fabric of it, of how we fund systems of that whole provider reported outcome, provider reported experience measures. So that becomes core to what we are measuring in what we're doing in the healthcare environment. At the moment, it's we will measure outputs. We will measure that an operation took place. We will measure that a procedure occurred, that a rehab physio session was completed. But we don't tend to measure the outcome for the patient. We don't tend to measure the as a funder. Was there a change in the pain score? Was there if we look at the measures in something like in a patient-reported outcome measure of the can I do my day-to-day activities? Am I independent in what I'm doing? Am I able to operate free from pain? We haven't got that built into the system of what we're actually looking for providers to deliver to us or to the patients that we're funding.
Yeah, so lots of interesting challenges for us to look at. Now, I've got a couple of questions that have come through. One from Nick Astwick at Southern Cross. He's really saying, is the key driver funders changing the way and the what that they fund? Is that really the key driver to the change in value-based care, or is it something else?
Yeah, again, good question, Nick. I think it's a system change. It's change management at that system level. If funders want to actually have a competitive advantage of being able to deliver an improved product to their clients, then I think this is the way that they need to go to actually look and say what is important to the patient and how can it be delivered. The other part is from a cost perspective. If we're looking at systems that are incentivizing outcomes over activity, there is the potential to actually start reducing a whole lot of waste that exists in the system that we currently pay for because people want it, because it's there. At the moment, we've got no drivers to say that a more efficient a more efficient system of delivery is going to actually be rewarded. In fact, typically it gets penalised. I had a conversation with a person in the States a few years ago who was commenting on, actually it was Harold Miller, I've used one of his pictures in the presentation. He said he was talking with some CFOs from hospitals there who had a fairly low focus on hospital-acquired infections. And as he dug into it more, it turned out as hospital-acquired infections were profitable for them because insurance companies would pay for them. So if we're keeping focus on a low-value output-based approach, we run the risk of actually incentivizing the wrong things in what we're looking for. And ultimately, that's going to cost us more money, and it's not going to actually lead to satisfaction for the patients that we're trying to look after.
Okay, I've got a question here from my colleague Brad Meek, who's currently working in private insurance but was previously with ACC. So he's got a question that spans both. And he said, considering value for the patient, where do you see the opportunities in situations where ACC may decline cover, but a health insurer has an ongoing relationship with that patient because they, I guess, support that cover need? How could that his question is, how could that transition be improved for better outcomes?
Again, there's a whole can of worms in this question too, and I understand it from inside an ACC point of view and from outside too of ACC looking at saying how do we ACC looking at things from a legislative point of view and saying that the legislation says this is what we cover and this is where the boundaries sit. And unlike, say, the public health system, ACC's boundaries are determined by the courts. It's decisions that have been made actually over time where people have challenged boundaries is where it's what drives it. And one of the big grey areas or areas where challenges come through is in that whole pre-existing conditions side of things. And the challenge, I think, there is to keep the patient at the centre and say whether if there's an insurance relationship and an ACC relationship, is actually the first call of order should be to actually say how do we actually get the right patient care, the right procedure. We can sort out who the payer is in the background, and I think is if we want to keep the satisfaction from the clients for whether it's ACC, whether it's a private insurer, getting that better relationship and having systems for doing that and keeping the patient at the centre is where we need to be going.
Mm. Okay, Graham, just changing tack. I've got a question that's come through from Richard. Has or will COVID fundamentally change the game with the stresses it's putting on the system?
Couldn't really say no to that one, and it has to. And there's there are so many things that are going on at the moment, from the distraction, from day-to-day service provision toward COVID, through to just the ability to actually deliver services on a day-to-day basis. And what I think we'll see from COVID, particularly in the short term, is increased costs because of the maintenance of hygiene factors, of social distancing, of the additional cleaning requirements. I think over time we'll see this sort of fade. I mean, nobody worries now about bubonic plague or sort of Black Death. I mean, over time these things disappear, and I think with COVID we will see the same thing. And if we jump forward 2 or 3 years, we'll be treating COVID, I think, more like the flu. And it's the health protection will be that we put in place will be more just the day-to-day health protection that we put in place in there. So I think it's a blip. It's a big blip, and it's very dominant in everybody's lives at the moment. But I think it's a blip that will normalise over time.
Okay, and I think I have one more question here, which is from John Seed from Healthcare Plus. And his question is, how do you get the clinician buy-in and take a long-term view and not a short-term financial view?
Yeah, look, I'm going to tell you a little bit of a story here. So it's one of the things we saw in the ACL work that was done was actually came when there was a failure, and that failure was a young woman who had an ACL ruptured, of course. Went through the process and was non-compliant with the prehabilitation stage, non-compliant with the pathway. Surgeon went ahead and operated, non-compliant with the rehabilitation, and so had a poor outcome as a result of it. And the team got together as a team and said, "Look, this isn't what we're about. This isn't what we're actually trying to achieve here," and introduced a traffic light system where the surgeon would not operate, or would go back and actually consult about operating if there was an amber or red light. They'd only go ahead and operate straight away if there was a green light. Now, as a funder, if ACC had put in place a system and said, to an orthopaedic surgeon, you're not allowed to operate until a physio says it's okay, we'd have had something that looked like a small thermonuclear tea party, small thermonuclear reaction to the UN Tea Party. It would be. It wouldn't have been something that was acceptable to the sector at the time. By changing the incentives, by saying actually what we want to buy as an outcome, what we're actually doing is giving a lot more freedom. We're not saying we'll pay you for A, B, C, therefore you have to do A, B, C. We're saying we're paying you for the outcome. How you get there is up to you. So you've actually got a lot more freedom to and a lot more self-determination in how you go about achieving that outcome. And that's the why I think there's an investment in time and energy at the beginning. It's why the work that was done with ACC, with the co-design process, was so important, because it actually got the ownership for the process and for the outcomes sitting with the clinicians right from the start. And it is a very much a change management process, as well as a funding commissioning process.
So, Graham, I think I've got one more question for you, and this comes from Stephen Potter at AIA. What role do you see case management having in value-based care, and how does this link with customer experience?
Yeah, look, again, a really good question. I see case management probably having a smaller role and less over time. What we're talking about here is really a transfer of accountability. So when there is a diagnosis that's been reached, an outcome that's been agreed in there and is being funded, it doesn't really require case management, because that becomes generically part of the treatment pathway through to the outcome. So the case management role changes from a person that will be trying to specify and organise things to someone who will be checking the diagnosis part at the beginning, the eligibility, and making sure that the outcome's been achieved at the end. So the role, I think, changes fundamentally to what it might be at the moment.
Okay, well, I think that's all the questions we've got at present. So, Graham, I was going to say thank you very much for your time, and I'd like to hand over to a colleague from AIA, who is Travis Higgins, who is going to give you a vote of thanks. So over to you, Travis.
Yeah, lovely. Thank you, Louise, and thank you, team. It's certainly been a real pleasure for AIA, I guess, to sponsor this event today, Graham, and I'm going to look up your details on LinkedIn after this. I hope you don't mind. Certainly keen to connect a little bit more. So I'm the head of claims here at AIA. We're really proud of the work that we obviously do with our claimants, and to jump on a call today and I guess to hear some of the proactive thoughts and thought leadership that is going through the industry right now is really important, and hearing some of the other companies that are on the call today. Look, I think I'm telling you all what you know, but we're clearly a primary carer-driven industry at the moment, and I think what you proposed here, Graham, in terms of pushing for outcome versus and I guess rather than the clinician leading the exercise, allowing the patient to lead the exercise, I think the whole mindset around that is gaining momentum. So certainly I'd like to thank the FSC for organising this event, and for me it feels quite timely, certainly considering my role as the commissioner in your model, as well as the comment, Graham, around sumo nuclear tea party. I've saved that comment and we'll be utilising that one later. But no, just on behalf of AIA, thank you very much, and thank you, Richard. I think I'm handing back to you, Richard, at this stage.
Thank you, Travis. Thank you, Graham, with such a well orchestrated way we all operate now seamlessly across miles and sea and so on. So a big thank you to Travis, a big thank you to AIA, and specifically to Graham for taking us on this discussion and journey, and for Louise to facilitate. So hopefully, folks, you enjoyed that discussion. It will be available to share and review. We will probably release it in the next couple of days as it's been on record. Coming up later this week on Friday is a discussion around the future of work. Is the future of work remote? And that's going to be a fascinating conversation on are these changes we've living with in COVID long-term and sustainable, or is there a new way of working? So huge thank you to everyone. Look out for your latest FSC comms, and you'll find out what's on next. Coming up on the 6th and the 7th of December is the two-day conference, which is now a digital show, and the program is just being firmed up. We're delighted to have Minister Henare in the mix. We're delighted to have Minister Robertson, Minister Clark, and on the other side of the house, Todd McLean, Andrew Bailey. So look out for announcements on that. With that, please enjoy your afternoon. It feels beautiful, irrespective of where you are, to be able to run down the beach or run down the park. Stay fit, stay healthy, stay balanced. And thanks again for joining this conversation. And on that, have a wonderful afternoon. Kia ora.